All right, friends. Hello, everyone, and welcome. We are watching people sign up, and so we'll just go over a couple housekeeping things, and then we'll get rolling. So, again, for those of us just joining, Marty, we are extremely excited to have you and just to learn from you today. Just even from our conversations in preparation for this, just what we've already been able to gather in terms of insight and really just knowledge from you is it's unmatched. So excited to help deliver that and answer some questions for our folks on the phone as well. So we're really excited and just wanted to say thank you again for jumping on and joining us. Today, we're going to do things a little differently that we would typically do at Provider Trust. So at Provider Trust, we'll go through a couple things at a top level. We do webinars all the time. This isn't new for us in terms of how we deliver value and a message to our networks and to our clients and to our friends in the industry. But to partner with somebody of this caliber and just what Marty can bring in terms of insight and direction and just counsel and guidance in these times is really unmatched. So we're really excited for that as well. Couple housekeeping things before we get going. This will be a live conversation. I can promise you that myself, I will do as minimal talking as possible to give the floor to Marty and let him really take the lead on a couple of topics. We'll be covering just COVID-19. Marty's become really just a national voice on this and what's going on with the healthcare landscape. And so excited for him to just give some updates and a current lay of the land and where do we stand today. We'll certainly touch on telehealth adoption and from a provider's perspective of what really matters and how to do this really well. And then lastly, we'll really just talk a little bit about the long-term impacts on healthcare, what that could look like, what are we already seeing in terms of trends and where are we going. So excited to get into that conversation too. Again, just a couple of quick data points as well as we get rolling. If you have a question, many of you submitted these in advance, which I do have. If you have a question throughout the presentation, please feel free to chat it in. Just ask a good question. I will be looking at those and fielding those throughout the call today, and certainly can field them and ask them of Marty as well throughout. So please, if you have a question, raise your hand, reach out, and I will do my best to delegate. If you have a question that we didn't get to today, can already promise that there will be a question that we don't actually answer today. I'll make sure that it's navigated to the right person, either at Provider Trust or to Marty as well. That is it. And with that, we'll get rolling. I'll give a quick introduction as well, just on kind of who we are and what we do. So I wanted to start by just saying really explicitly is just a thank you. So many of you are our clients, our friends in the industry and our partners. You guys are on the front lines. And so Marty and I are coming to you live from our respective homes because we realized so much of us, the best thing that we can do is just stay at home and stay safe. And we're so grateful for the work that all of you are doing to keep us safe. So just from the bottom of our hearts, thankful. We are so grateful for the work that you and all of your teams are doing. A little bit about us. We just Provider Trust. We say made with love in Nashville, Tennessee, bringing insights from America's healthcare capital. This is a very familiar slide to those of you that have been on a session with us before. For those that have not, we believe that a smarter healthcare makes a safer healthcare. And so we spend so much of our time researching and building analytics and monitoring tools to help catch fraud, waste, and abuse and keep it out of the healthcare system. And really that's at our core in terms of what we do. When we say this is our sort of vision, our purpose, and our mission for who we are and what we believe. I know that so much of this is aligned with the work that Marty's been doing for so long as well. But our vision is that and the role that we play in healthcare is that if we can focus our time and resources on data and monitoring, we can help lead to patient safety, which is such a big thing for us. And now, without further ado, I'll give you just a very brief background. I could probably spend a full hour just talking about Marty, but I'll do so and summarize very quickly. So we are just honored to have Dr. Marty Makary join us today. Dr. Makary is a professor of health policy and management at Johns Hopkins School of Public Health. He's a professor of surgery at Johns Hopkins University School of Medicine, a member at the National Academy of Medicine, the editor-in-chief at M.P.H today, is a leading voice for public health, is a featured contributor, both past and current, writing for the Wall Street Journal and USA Today, has been featured on CNBC and Fox lately as an industry expert and a national voice on COVID-19, has published over 250 scientific articles, including articles on patient safety, vulnerable populations, quality of care, best practices, and the evaluation of medical interventions. And so much of that work is so near and dear to our hearts at Provider Trust. And then lastly, Dr. Makary is an author, and a best-selling one at that. His book Unaccountable was turned into a hit TV series, The Resident. His newest book, The Price We Pay, tells the stories of healthcare's disruptors and has been described as a must-read for every American, and a deep dive into the real issues driving up the price of healthcare. And if you haven't had a chance to read some of what Dr. Makary's written, even this week, we've been reading his op-eds published on M.P.H today, and it's fascinating and awesome. So if you have a second, please go check that out. And without that, I will take this off of a screen share and really just allow you to learn and hear from the experts. So Dr. Marty Makary, anything I missed in that introduction?
That was already plenty excessive, but great to be with you, David, and great, keep up the great work at Provider Trust.
Awesome. Thank you so much. So I'd just love to learn a little bit from you and kick us off today on really, what's on everybody's mind, which is COVID-19. I think a question that so many folks on the phone have had is, from your perspective, kind of where have we been? Where are we at today? And then I think what everybody's wondering, and the question that keeps coming, is kind of what does ending look like for you? What does that look like from what you're seeing?
Well, great questions, David. I sort of became an involuntary expert in COVID-19 simply because many of us in public health at different schools of public health around the country were very concerned by late February that we had seen all this writing on the wall starting in mid-January that was very apparent. You could argue maybe a little earlier, but by mid-January, it was very clear what we were in for, because this infection, in fact, had seeded in many places around the world. And we had a preview of what was going to come based on Wuhan province in China. So many of us waited for those alarms to be sounded. And when we didn't hear any alarms being sounded, we decided to do it ourselves. And we started in February to talk about increasing ventilator production and increasing PPD and changing our supply chains. And, I hope to this day, we're going to learn lessons so we never in the future have to be shopping in China for ventilators and medical supplies. And these are real issues. But I think right now, we'll have a time to re-examine where we are. But right now, we need to focus on giving people hope, letting them know the silver linings, giving them good, accurate predictions on when we can get back to work. And I do think, David, there's a lot of good news out there. I think, for example, we're going to save thousands of lives every year for the next 20 or 30 years, simply because we have finally gotten through to folks on good hygiene and social distancing that will benefit thousands of people during the seasonal flu each year. Before we in the medical community were sort of seen as people telling folks to obey the traffic limit, the speed limits. And we were kind of downplayed for, of course, we all know we should do that, but we do what we want to do. This is the first year where all of that stuff finally broke through. And I think we're going to see a lot of benefits from that. Medication and drug development has been skyrocketing. Looking at surge capacity at hospitals has been a front and center issue, which we need to think about, not just for pandemics, but also for natural disasters, for bioterrorism, for mass shootings, all of which are more common nowadays. So these are important issues of surge capacity that we are learning from. And I think there is some good news in terms of the trajectory of this virus. It is, Sunday was a great day. I felt on Sunday that we converted from a lot of unknowns to a lot of knowns. We could kind of see the trajectory of this pandemic playing out, and it's going to be rough and it's going to be hard, but it is not going to be some of the most dire zombie apocalypse scenarios that were real possibilities coming up until the numbers that we saw this weekend.
Sure, and some of the data that we see, and some of what's been reported on the news is kind of looking at the apex of that curve. We're looking at Governor Cuomo mentioning potentially in New York that apex of that curve could potentially be within the next 7 to 10 days, and that we're starting to see early effects. I'm just curious on what your perspective is and the data that you're looking at, and kind of what story does that tell?
Yeah, so when I hear political leaders speak about the issue, I, of course, interpret those comments through the lens that they try to provide hope, try to be optimistic, and they're trying to encourage people to do what they're recommending as a temporary measure. So they always talk about the positives. By the way, I would not be surprised, and I think you can plan on the next 3 weeks as we go into the peak in the United States, every day, the media and our political leaders claiming victory that we have either approach the peak or we hit the peak every day for the next 3 weeks. We know what this peak is going to look like, and I do think Governor Cuomo is correct. I think it is going to be in the next 7 to 10 days. I think Dr. Fauci is correct in that it was a roughly 45-day incline, and the decline is roughly symmetrical to the incline. But I would guard against people making conclusions from what is otherwise seen as statistical noise in the day-to-day variation. Probably the best statistic is the 3-day moving average of the number of daily deaths, okay? The second closest statistic that I follow is our ventilator capacity in the United States. In other words, how overrun are the ICUs? And have they hit the brink of rationing ventilators or exceeded that? Now, you hear different things, and what's happening on the ground, as many folks on this call know, may not be the rosy picture that we hear about in the media. People are getting hammered right now in the ICUs. Workers, nurse practitioners, respiratory therapists, critical care nurses, intensivists, those with skills that can work in an ICU but are not full-time intensivists, and they're helping out. So, I would recommend people not overinterpret individual numbers. For example, New York, about an hour ago, reported 799 deaths in the last 24 hours. That's up from 737, and that's up from 3-day moving averages of every 3-day period since this thing started. So we have still not peaked. The good news, and the reason I was optimistic on Sunday, is the rate of new admissions to the ICU. That rate is decreasing. We're still adding to our ICUs, but the rate is decreasing. And the number of new intubations, which is the third metric I follow, that has declined. And finally, that fourth metric is the wait time for 911 calls. You can pretty much forget about the number of diagnosed cases. And when I see those numbers, and it's loaded all over social media, and I see it on Twitter all the time, although I try not to look at Twitter too much, since Twitter generally is a nasty place. But look at the Johns Hopkins numbers. No one believes these numbers are accurate because they require that somebody had symptoms. We know some people don't. And it requires that they got a test and that test result was reported up. So we always knew the numbers out of China were not accurate. We always knew the numbers out of Iran were not accurate. And we started to believe some of the numbers out of Italy, knowing that they were massively under testing. So when you hear we have more confirmed cases, that's a reflection of the testing.
Yeah, that makes perfect sense. Here's you mentioned just current state in the ICU and what does that look like? And one of the pieces that you published this week, which I loved, which was, really a call to action for health systems across the country to start preparing for multiple waves. And what does that look like? And I'd love for you to just spend some time there and just for the folks on the phone that may actively be involved in that. So a lot of people that we have on this call today, and there's a few hundred of them, that are listening in are working in a healthcare provider organization or a health system in either HR or compliance. And so they're following the regulation, and they're also following just the staffing elements of this. And so for them, that second and third wave concept is critical to make sure that what can they do now to best prepare for that wave of either volunteers or staffing up, or what does that look like? And I'd love for you to just expand upon that notion, because I love what you wrote.
Well, thank you. The reason I wrote that piece in M.P.H today about how we staff our hospitals appropriately was because I saw 2 reports in the news media that retired doctors were coming in volunteering to help and work in the hospital. And I just thought to myself, I love that idea. I love the altruism. I love the self-sacrificial nature that's intrinsic to the medical profession. But that's a really bad idea to have 80-year-old docs come into the front lines of the ICUs. They are at very high risk. And I know the mentality. My father is one of them. He's 80 years old. He's a retired physician. They just want to serve. They want to take care of people, and they put themselves second to their patients. We need to say, look, that's a noble virtue. We admire that, but it's not wise. You are at extremely high risk, and let's just put you on the second string team or the third string team. And let's organize our hospitals by taking an inventory of staff and figuring out who are full-time intensivists, who are folks who do that as a living. They may have board certification or just a lot of experience in intensive care and critical care management. By the way, a lot of anesthesiologists can do critical care management. And then let's look at the second string team. I would include people like myself, those who are close enough to our residency training. I'm a surgeon. In our general surgery residency training, we spend about 1 year out of the 5 years. It's amazing. I almost forgot how many years I spent in residency. Out of the 5 years, we spend 1 year in critical care training. I feel comfortable managing a ventilator. Now, sure, certainly an intensivist full-time should do that on the first string team, but what happens when they're burnt out, or they're tired, or they get infected, or they become a patient? That's time to deploy our second string team, and it should not be a last minute scramble. We can do an inventory of our staff, ask the physicians, do you have training and feel comfortable? Now, if they feel too rusty or they don't have enough experience, or they don't feel safe doing it, fine. That means we're not going to put them on the front lines. But many internal medicine doctors have had critical care training, surgeons and others, and they would feel comfortable managing patients for basic ventilatory support. So I think we can organize around our skill set, and we've never really done this before, but we are seeing Kaiser, for example, assigning rheumatologists to work the coronavirus hotline for their beneficiaries. We're seeing Northwell Hospital in New York City assigning surgeons to the second string ICU team. We're seeing them redeploy orthopedic surgeons and dermatologists in the emergency room. So we can play some zone defense, I think, at a time like this.
Yeah, that makes sense. When I guess in doing that and making sure that we've got the right coverage and can within the 4 walls of the health system that I'm helping manage or helping to run, when does it make sense to look external and saying, gosh, we have to put out a call for volunteers, or because we don't have the staff, and we've started to see some of that happening certainly in New York City, but starting to slowly see that happen in other parts of the country as well. And I'm just curious, kind of what are the metrics that you would be in tune to saying, gosh, now I've got my first string, my second string, and my third string, and maybe my fourth string is volunteers because I don't have that manpower. What are the metrics that you'd be paying attention to say, gosh, when does it make sense to organize around a potential fourth string?
Yeah, I think we cannot over prepare. And we've said this many times when we were in the media, and I took a lot of arrows for making projections that this was going to be a big problem. If you look back, we did not hear anything from mid-January until mid-March about ever from any of them. And Dr. Fauci, who I respect in so many ways, I pushed him hard. Never once did we hear, we need more ventilators. We need to prepare for second string teams. We need more PPE. We need to get ready to potentially close schools. We need to stop non-essential travel. We need to get people to work from home. We need to get restaurants to diversify into the delivery business lest they go out of business. Many of these warnings were silent, and that's why many of us spoke up. And as we couldn't get to the Mardi Gras organizers. I didn't even know who to call. But literally some friends and I had a conference call, and we decided, hey, in the absence of these recommendations, knowing the data, seeing what's happening in China, calling the doctors in China and Italy, finding out exactly what's happening in their ICUs, what should we do in the absence of other people doing things? And we decided to call the mayor of Austin and tell him, we urge him to stop South by Southwest and the NCAA tournament, which was hard because I love basketball. And that was hard, but many of us said, we cannot over prepare. We don't worry about over preparing. That is not our greatest risk right now. Our greatest risk is many, many people dying. So I do think, to your question, we cannot over prepare for this. And I do think it's a good idea to think of fourth string teams. I think it's a good idea to think about, how do we allow volunteers to practice? There's a good story in the New York Times today about a doctor, I believe from North Carolina, that traveled to New York when she heard Governor Cuomo invite volunteers to come help New York. And she tried very hard to volunteer, and the hospitals had such peacetime protocols set up at a time of war, and it was very difficult for that individual to volunteer. And finally, the hospital said, why don't you go work for a staffing agency, and then we'll hire the staffing agency. The doctor said, I don't want to be paid. I want to volunteer. And the hospital said, well, it's going to be easier if you simply go through the staffing company. So I do think it's worthwhile for us to think about volunteerism right now.
Yeah, that's a really good answer. We something that's been really hot in our world too, because we deal so much in the regulation and the changing of license portability and state board waivers that are allowing people to practice from out of state and be able to respond in time of need. And with that, something that's been on our radar at Provider Trust is kind of the thought and really the fear around monitoring fraud, waste, and abuse around that too. And I know that's the whole other side of that coin is we want to encourage and make it easy for folks to volunteer and get into an emergency room to be able to help, or an ICU. And the other side of it is, how do you do so safely, and how do you do so just keeping the patient's safety at a top level? So I'm curious on, has that come up in any of your research? You've researched and written so much about patient safety. How has that started to play into some of the changes that we're seeing from a regulatory environment?
Well, it's a great point, David. And if you think about it, we don't want, for example, that volunteer from North Carolina simply to say, hey, I'm a doctor, and then them to be given the keys to the ICU without any background checks. We know fraud runs rampant at any time of crisis. We're seeing it with the PPE suppliers. And so it is important to have those checks. And by the way, this is not the first time we've seen it overseas on the mission field. We've seen it sometimes at hospitals where there's a licensure issue in one state and the physician jumps to another state. So all of those who work in the medical staffing areas of hospitals, the medical staff offices and the credentialing individuals, thank you for what you're doing, because we rely on those processes that you've set up, even in a time of crisis, to make sure that there is still basic verifications. It's never perfect. There are no perfect metrics out there of identifying somebody who is safe and high quality, but there are indicators of concerning attributes, which is the entire process that all of you are doing. So, David, I want to thank you for what you do in Provider Trust and all the people listening. I know there are many people who work in that medical staffing area. I had a chance to visit with many of them years ago at their annual conference. So I think healthcare is a team sport, and we're relying on your good work right now. So thank you.
Yeah, thank you. I really, really appreciate that, and would echo that sentiment for everybody else listening on the call too. Just thank you. Last question on this, and then we'll move into really the conversation around telehealth and how does that sort of shake into all of that's going on. Is I'm just curious, from your perspective, what are the quote unquote sources of truth that you rely on right now, and where are you getting when you're looking for all the metrics that you said before? Is there any guidance or advice that, and maybe even specific source examples that we could give to the folks on the phone to say, here's where you go, here's what I'm looking at, and what am I looking at on a daily basis? I'm just curious what those are for you personally.
Sure. I do think that there are some good modeling systems out there. I personally use all of them, but the IHME has probably been the one that's closest to hitting the mark. I do think whether or not we have 61,000 deaths at the end of this, or 81,000, or 240,000, does not change what we need to do on a day-to-day basis. We need to prepare for the highest end of the range. Even though I follow these models, I think the biggest limitation right now is ventilator capacity and staffing capacity. So that's what I follow regularly.
Yeah, appreciate that. I know that's helpful for everybody listening in too. Let's switch to telehealth a little bit. So just curious, as a personal provider, right, and your personal experience, have you used telehealth, and what's been your experience just from a personal perspective?
So, it is a little embarrassing how underdeveloped telehealth has been in the United States coming into this crisis. And I think we're learning a lot. Right now, we're realizing that telehealth is an important feature to increase our national security through surge capacity building. We're learning that telehealth is critical for accessing patients that come from those that have barriers to getting to the hospital, specifically those in rural and other low-income areas in the United States, where they just simply can't get an expert opinion quickly, especially at a time when the risk of getting the infection in the waiting room may be greater than the risk of whatever they're coming to see us for. So telehealth, unfortunately, has been reimbursed poorly. As a matter of fact, most payers have not paid for telehealth, or they've paid for it on a radically different scale. Mm-hmm. We did see, using an 1134 waiver by Medicare, we did see a massive transformation where Medicare announced for all 60 million beneficiaries that telehealth would be covered with total reimbursement parity to in-person visits. We're now pushing states, and I'll have an op-ed coming out tomorrow, to encourage the same for Medicaid programs. When Medicaid is underfunded, our state hospitals are underfunded, and that's something that people don't always appreciate. So we did get parity at the federal level. We need it at the state level. And finally, the telehealth providers that have been overloaded, and most of them have had waiting times of 4 hours to 4 days. It is telling us that we should increase capacity. So we're seeing companies like Sesame Health, one of my favorites, allow physicians to transform their practices into a virtual practice or a mixed practice. It shouldn't be hard. It shouldn't cost money. I think the Sesame Care platform is free. Mm-hmm. It also allows easy scheduling and direct payment. And if you think about the cost of billing, coding, which we hate, by the way, as physicians, collections, and that entire process, if we could eliminate that, we could actually offer prices 30 to 40% below what we charge through the billing coding maze. So I think that's the revolution in healthcare. Maybe that's one of the silver linings that comes out of this, in addition to the better practices and the increased research and development and the reducing of the FDA barriers to doing trials. We are seeing many bright spots come out of this. And even though this epidemic is terrible and it's putting a horrible strain on healthcare workers, there are going to be some positives that come out of this.
Yeah, and along those lines, we did just get, I just watched it come in, a question from Lakeisha, who's asking just what elements of telehealth will continue to be utilized after this pandemic. Just curious on your perspective of, along those lines, we are seeing telehealth and the expansion of that, especially from a patient or a consumer perspective, be a benefit. Kind of what are the elements that you think will stick long term?
I think follow-up visits, number one. It doesn't really make sense to come in for a follow-up visit for certain things. Other things, like when we look at surgical wounds, sometimes we do want to lay hands on a patient. But no one has ever done the inventory of all medical conditions and all patient visits and categorized them into requires an in-person on-hands exam, versus does not require an in-person on-hands exam. I don't
Mhm.
think anyone thinks that it's enjoyable to drive to your local hospital, fight in a parking garage that you have to pay for, get accosted by security to get a name tag or badge, sign into a clinic, wait in a waiting room, and then see a doctor for 15 minutes for a urinary tract infection where we typically don't do an exam. We do a history
Mm.
and then get a prescription. Those days hopefully are behind us. And I think we're going to see this delineation of services that
Yeah.
can be better rendered through telehealth.
Yeah, that makes sense too. Are there any, just from a provider perspective, are there any unique elements as it relates to electronic medical records that are specific to telehealth, either from a compliance perspective or a regulatory perspective? I know that we did have a few questions come in, and I know that's very, very specific. But is there anything that you've noticed that would be a compliance consideration as it relates to telehealth?
Well, certainly anytime you have a new way of doing business in healthcare, it opens the door for abuse. And even though right now we've reduced the barriers so that doctors can use Skype or FaceTime to do visits without, it doesn't have to be too fancy. The electronic health records have not really been set up for this with a good user interface. That's going to change. I think that's going to be one of the big changes we get out of this. The electronic health records, by the way, not a very popular subject among physicians. If you've, some of the people on this call know of physicians who have retired simply because they didn't want to get a username and password.
Mm.
And I think, I think the electronic health records system was set up for billing and coding with some goals of interoperability for which many have fallen short and frustrated physicians. It's also lacked the user interface that many of us were hoping for. And for that reason, it's a touchy subject among many staff. But I think that's going to change. And that's also one of the silver linings.
Yeah, that makes sense. Broadly, sort of, I know this was a broad question that was the most popular that people submitted, is just what are sort of your predictions and projections for the more of the long-term implications and the things that will stick, maybe not just positive, but potentially also negative as well, or out of this pandemic for our healthcare system? What are the long-term impacts and the ways in which we would anticipate our healthcare system shifting or changing, potentially even a little bit more permanently?
Well, I hope we recognize surge capacity is important. I hope we recognize that supply chains need to be based in places that are reliable. I hope we get country of origin labeling on all medications from here on out forever, including medical devices. And I hope we rely less on GPOs and more on an open market. The fundamental problem in healthcare, as I write about in the book, The Price We Pay, is that healthcare is a non-competitive market. Mm-hmm. And in order to address that and cut the waste, you can do what you're tempted to do, and that is create rules and barriers within the non-competitive market, or you can redesign the market to be competitive. And mm-hmm. one of the great positives of this is that we're seeing many of the barriers practicing across state lines reduced. We're seeing clinical trial protocol barriers at the FDA reduced. If there's one theme, it's been barriers are being reduced. We're seeing the barriers to do telehealth reduced. One of the reasons we got a late start with COVID-19 is that the test, even though the CDC gets a lot of blame, and there's certainly enough to go around, the test to look for the virus was submitted to the FDA for approval. And the regulator told the person who submitted the application that it was not being processed because it also has to be submitted by snail mail, which some of you may not even know what that is, but it's the paper postage system. And then they submitted it, and they were told that the files have to be burned on a CD-ROM and include a printout of what was already submitted electronically. Those games have been going on for years. It's been a major limitation to innovation and advancing health, and we're finally fixing some of those things now. So I think there are some real positives.
Yeah. So one of our listeners on the phone asked a question that I thought was really interesting, and it is kind of it's a different angle, but it's from your perspective, and you're watching so much of this happen on a global level. If you could maybe share a specific story of hope, and something that's just been really powerful that you've seen, that just would provide that to some of the listeners on the phone. I thought that a few folks asked for that specifically. I thought that it was worth making sure we at least squeeze that in.
I think it's good for us always to talk about some good news,
Yeah.
as we talk about the different scenarios here. And I think there is a fair amount of good news. I've been most inspired about those who have donated their plasma so that the cryo antibodies can be used for those who have active infection. I've been inspired by the people volunteering right now. I think there's a lot of good news to go around. Last night we saw the CDC start to issue one of the first sort of positive recommendations, and that is to allow essential workers to go back to work with certain conditions. They wear a face mask for 14 days. They have a temperature check. They do social distancing, and that common surfaces are routinely cleaned. I personally added on the national media this morning my own addition to that guideline, which is that those guidelines should only apply to low-risk individuals. We don't want anybody who's had an organ transplant or is on immunosuppression right now out there. They need to be hunkered down.
Mm-hmm.
We're going to see more green lighting. We're going to see more and more, probably right after the peak, which is the right time for it. We're going to probably see green lights for young, healthy people to go out there. If you think about the old days when parents would wonder, do they let their kids get chicken pox because it's less dangerous in childhood than it is in adulthood? We may start to see a recognition that it is hard for this virus to hurt somebody young and healthy. And with no risk factors, slowly allow those individuals to march forward to get America back to work. Maybe that roadmap to getting back to work also includes those who test positive for the antibody. But people should know that the antibody is not perfect, and that the antibody test is not perfect. An early study from South Korea published just in the last few days suggested that up to 30% of those who get the infection may not really mount a meaningful antibody response. And maybe that could be a parallel with reinfection rates. We've seen that with seasonal flu vaccines each year. We know older people really don't mount a good antibody response. So I don't want people to freak out in September when the media generates hysteria around a new case discovered in Detroit, or there's been somebody, on a cruise ship that has the virus. We anticipate a second wave, short of some medication that's a miracle. And that second wave should be more contained and controlled. We also have all the guns ready to go. So when we know we got to social distance again and limit non-essential travel and do certain things, we may need to do that for a short time in the fall, but I think it will be very manageable and successful. And people should know now not to freak out when they hear of cases in September, because I think it is likely. Yeah. Even though this the current wave should end by June or July.
Yeah. I'm really glad you brought that up. And I think for right now, so much of what we talked about early in this conversation was sort of mission critical immediately for health systems to start preparing. I'm thinking of the conversation around the second and third and potentially even a fourth wave, to prepare now to get us to June and July. If, for the folks in staffing and credentialing and compliance and regulation on the phone, is there any recommendations that you would have for what does preparing for wave 2 look like? And I know you mentioned we've got a lot of it now, but is there anything specific that we should just make sure we're not forgetting about, as wild as that can sound because of what's happening today? Major considerations for the healthcare industry for wave 2.
Well, that's a great question, David, because there's a great paradox at hospitals right now. Some people are busier than they've ever been before, and other people are bored. They simply don't have the skill sets of the services that we are focused on right now. And so they are trying to help in different ways. Sometimes they really don't have much of a practice. They're just going for 3 months, scaled down or reducing things to telehealth visits only. So I think we need to think about who comes off the front lines when we have a second wave. In September, when we realize that hospitals may on average have 5 or 10 COVID patients again, where do our command center staff come from? Are we ready to backfill those positions? Do we have second and third string teams? Some hospitals in the US may not get hit very hard. That is, with their current capacity, they may be able to manage the increased influx of patients. I worry a lot about New Orleans, Dallas, Denver, Oklahoma City. The question, what's worse, a busy public transit system like New York, or a late sheltering and a very comorbid population, as in Louisiana? That we got that answer this week. On Friday, it was very clear. The death rate per capita was double in Louisiana than it's been in New York. That's remarkable considering how congested New York is. And so I do worry about areas with high comorbidities and a lot of people at risk. And I think we can use some of that information to anticipate what to expect with our capacity building in terms of staff for the current wave and also for the second or possible third waves.
Yeah, that makes sense. Talking for that second wave and anticipating that, and so much of we find ourselves as a vendor and a partner, right? As in helping people prep for what's to come, and knowing to stay quiet when there's not much to add in the current situation is. In prepping for that second wave, is there any sort of models that are already out there that are predicting sort of what that looks like in terms of length, or what that looks like in terms of just amount of time or amount of guidelines or restrictions that might be there? I'm just curious. I know so much of the focus has been on modeling now, and rightly and appropriately so. Have you seen any models or anything like that out there about a second wave yet, or is everyone just currently focused on the first?
I've not seen anything reliable that I am banking on for the second or possible third wave model. And I think there's just too many moving parts right now. I think we can look at history. We can look at the Spanish flu of 1917, which ironically didn't start in Spain. It probably started in Kansas. Yeah. And we can look at some of these other viruses, the Hong Kong flu that had a second wave. And we can look at the general projected immunity. One philosophy has been test the heck out of everybody, test every person in America every day, and that'll be the solution. I don't agree. I don't think testing is the solution. It is a tool, and it's a tool that's used best in the earlier stages when we need to do contact tracing and isolation. And it's a tool used for clinical trial design in the ICU. But there's a point where, what do we do when 1 in 2 people test positive, or you tested negative and the next day you want to get tested again? So I think we need to recognize that history can teach us some lessons. Some of those lessons are that second waves can be manageable. We have more tools now than we've ever had before. We have information we can disseminate. In the Spanish flu of 1917, one Army chef was sent to Europe and was believed to be the individual that carried the virus to many of the soldiers who died in World War I. And it turns out that more soldiers died of of the flu in World War I than from bullets. And so if you look back, contact tracing can be powerful. Social distancing works. And I think there's a lot of good lessons we can learn here. And if we have all those lessons at the top of mind, and we don't simply go into a hysteria mode in September when we start hearing about more cases, we can be very aggressive with this.
Yeah, I appreciate that. And as we wrap here, I have 2 more questions that are potentially a little bit lighter. One, this actually was asked by several folks in advance, which is, we see on the news in sharing some of that good news, hand sewing some of these masks, and volunteers that are sort of making their own to wear. And there's a few folks have asked, how actually effective are those? Right? They're not, quote unquote medical grade, right? Is that a practice that as a medical professional that you'd recommend us all doing, or keeping up from a volunteer basis?
You know, I'm amused at the conversation about masks right now. I've been wearing a mask most of my adult life as a surgeon. And the first time I wanted to fix it and it was bothering me. The second time it was itching a lot. And then by the third time, I didn't even realize it was on. And the masks have become more and more uncomfortable as healthcare has resorted to
Mm,
cheaper and cheaper supply chains,
mm,
where sometimes I feel like I'm wearing a piece of Xerox paper on my face.
yeah.
So anything is better than nothing. And part of the reason we're in this PPE crisis is we decided as a society, the regulators required that they have to approve PPE. You just can't wear a gown, they have to approve it. And instead of simply approving the
Hmm.
standards, they actually had to approve the product. That's why we got so behind the eight ball. So if anyone wants to make a mask, I encourage it.
Thank you for that. And then the last sort of final thoughts before we wrap here is really as we close out this call, you're speaking to an audience of compliance and HR folks and leaderships at the executive level that are managing this at their healthcare providers and staying on top of this as best they can. I really just wanted to yield the floor to you. Is there any final thoughts or anything you'd like to just say to that audience before we let everybody go back to their Thursday?
Well, I'm very impressed by those people who are keeping our credentialing and staffing offices running sound and ensuring that we've got good quality and safety standards. So again, thanks for what all of you are doing. I would say that as we are asking everybody to change our routines and we're going into disaster mode here at many hospitals, that this is temporary, that by June or July, we should be seeing the green light. And that when we do let people get back to work, it may not be all at once. It may be a phase in where different types of subgroups go into work first. It may be that young and healthy people lead the way. It may be that those with the antibody follow. It may be that those who are simply low risk, that is, they don't have risk factors, come in before those without risk factors come in before those who have risk factors. So don't be surprised if we start
Mhm.
seeing a phased rollout of getting back to life as usual as soon as we hit these peaks, which is going to vary by the city, but they'll probably range from mid-April to end of May.
That's awesome. Dr. Makary, this has been incredible. I just so appreciate you taking the time and jumping on the call here to really give a perspective and an insight that's so unique and just so helpful right now for all of the folks on the phone. So from all of us and all of the, the few hundred folks that are on mute right now, I'm so grateful for you, for the work that you're doing, for all that you're doing, certainly for us as healthcare professionals, but also for this country. So just on behalf of all of us, thank you. Just so enjoyed the time today. And this has just been absolutely tremendous and wonderful.
Well, thanks again, David, and thanks for everybody who's on the call. I will try to keep some good updates out there on Twitter and LinkedIn and other social media outlets for those who are interested. But thanks for having me on. I enjoyed the conversation.
Awesome. Thank you again. And then for everybody else listening still, we will push out a follow-up email and link to Dr. Makary's social media account so you can follow along with as he's posting and as he's interacting. We'll make sure you guys can stay in touch. So again, for everybody listening, thank you guys so much. And then for Dr. Makary, thank you again. All right, everybody, enjoy your Thursday afternoon.